Welcome back to the Critical Care Shock Lecture Series. In this session, we'll be discussing basic hemodynamics. Quickly, disclosures and disclaimers. I have no relationship with industry, nor do I have any financial conflict. Let's review our objectives and goals for this session. We're going to discuss pressure, resistance, and flow, which are essentially the components of hemodynamics. In more detail, we'll look at some brief cardiac anatomy, right heart pressures, pulmonary artery pressures, left heart pressures, arterial pressures. Then we'll move to resistance, both systemic and pulmonary. Then we'll move into flow, stroke volume, and cardiac output. We'll throw in two formulas, two calculations, CPO and PAPi. We'll also talk about a specific ratio, a pressure ratio. And then throughout the session, we'll discuss heart-lung interaction and heart-lung variation as it pertains to hemodynamic monitoring. When we look at the word hemodynamics, hemo is blood and dynamics is motion. So essentially this is blood in motion. With that said, it's best to start the presentation by tracking the flow of blood through the heart. As we all know, the blood travels back to the heart via the superior vena cava and inferior vena cava. This merges in the caval-atrial junction, and the blood then drops into the right atrium. Blood travels from the right atrium to the tricuspid valve, into the right ventricle, from the right ventricle through the pulmonic valve, and from the pulmonic valve it travels to the pulmonary artery. From the pulmonary artery, deoxygenated blood travels to the lungs where oxygen and CO2 is exchanged, and then the blood travels back to the pulmonary veins, to the left atrium, through the mitral valve, and lastly through the left ventricle into the aortic valve and out through the aorta. I'm constantly amazed by the morphology and the geometry of the heart, especially the right heart, remembering that each ventricle has an inflow valve, an outflow valve, as well as an apex, body, and a base. Now that we've reviewed the flow of blood through the heart, let's review some of the average pressures seen within the cardiac circulation. But before moving forward, let's remember that the right heart is thin-walled. It's a low-pressure system. In fact, the pressures are considerably lower than the left. Starting at the right atrium, we have a mean right atrial pressure of 4 millimeters of mercury. Moving down to the right ventricular pressures, we have a right ventricular systolic pressure of 25 and a right ventricular end diastolic pressure of 4. Moving to the pulmonary arteries, we have a pulmonary artery systolic pressure of 25 and a pulmonary artery diastolic pressure of 10. Blood goes out to the lungs, comes back to the pulmonary veins, and lands in the left atrium. We have an average left atrial pressure of 8 millimeters of mercury. The blood then moves to the left ventricle. We have a left ventricular peak systolic pressure of 120, and more importantly, a left ventricular end diastolic pressure of 4. And then we move into our aorta with a mean average aortic pressure of 120 over 80. Based on knowledge we've gained so far, we can look at the mean arterial pressure as the main systemic driving perfusion pressure. And we know that MAP equals cardiac output times systemic vascular resistance plus right atrial pressure. We can also assess specific organ perfusion. In this example, we're looking at the coronary perfusion pressure. And this is the aortic diastolic blood pressure minus the left ventricular end diastolic pressure. So in this example, it would be 80 minus 8, which would equal 72. As most of us know, we also can look at cerebral perfusion pressure, which is MAP minus intracranial pressure. And we can even measure the intra-abdominal perfusion pressure by looking at the MAP minus the intra-abdominal pressure. Before moving forward, I do want to cover some discussion points. Monitoring procedures do not improve outcome. You'd be very hard-pressed to find consistent literature telling you that a specific type of monitoring improves outcome. And I try to remind myself of this. As I'm increasing my monitoring procedures, I need to ensure that I'm treating my patient at the same time. It's very difficult to talk about hemodynamics without talking about increasing the level of hemodynamic monitoring. So every time I consider increasing my monitoring, I ask myself two basic questions. Can increased monitoring give me new information? And will it change my management? And if the answer is no to those questions, I should think twice before escalating my level of monitoring. Next is pressure does not equate volume. And actually, there's very poor correlation or poor relationship between cardiac chamber pressures and the actual cardiac chamber volume. Next, dynamic measures are better than static measures. And we'll talk about this in depth in our next Critical Care Shock lecture series when we discuss volume administration and fluid responsiveness. But for right now, the definitions of dynamic and static measures are as follows. A static measure is a measure of something under one load condition, where dynamic is a measure of something under two different conditions or two moving conditions. So an example of this would be a pre-post test from volume administration, a pre-post test from a passive leg raise test, or even better, a difference in heart-lung interaction, heart-lung variation. And then lastly, hemodynamic monitoring is hard. It's hard to teach, it's hard to learn, it requires practice, it requires repetition, and it truly is one of those things, if you don't use it, you will lose it. I suggest that you really familiarize yourself with the core concepts and the average values, and then be kind to yourself with some quick reference material that you can utilize on the job. I would like to go over two basic physiology concepts that will help us down the line before getting into the bulk of our lecture here, and that's really the heart-lung interaction. Dr. Pinsky has described the heart-lung interaction as a pressure chamber within a pressure chamber, and it's vital to understanding when we're learning and interpreting hemodynamics. Taking a closer look at a pressure chamber within a pressure chamber concept, we essentially have two compartments. We have the abdominal compartment and we have the thorax or the thoracic space, and these are divided by the diaphragm. Within the thoracic space, we have the chest wall and the diaphragm. This would be pressure chamber number 1. And within that pressure chamber, we also have the great vessels throughout the thorax. And then within the thorax, we obviously have the heart. Surrounding the heart, we have the pericardium. This is the pressure chamber number 2. It's important to remember that right now, I'm spontaneous breathing, not on the ventilator. I'm functioning on a negative pressure system. That is, my thoracic space is more negative than my abdominal space, and this is beneficial. This is a beneficial pressure gradient for venous return, and as we learned in our last session, our shock intro, venous return is a component to the end result of cardiac output. Now we put somebody on a ventilator and we give them positive pressure. That is, we're introducing positive pressure into an otherwise normally negative compartment. This increases our interthoracic pressure. With increased interthoracic pressure, we have increased transmural pressure of the great vessels. That compresses these great vessels. It increases resistance. And since the right heart is a low pressure system, thin-walled, the interthoracic pressure induces increased transmural pressures, which compress the right heart. This increases the right heart pressures, and this impedes venous return. Then you have a cyclical decrease in the cardiac output based on where the patient is in their breath. So simply stated, when you introduce positive pressure ventilation, you increase interthoracic pressure, and this compresses the great venous vessels and the right heart. It decreases venous return and subsequently cardiac output. To expand on this concept, let's take a look at this graphic. Let's focus on the red box here. We have airway pressure and arterial pressure. It's easy to conclude that the patient's on positive pressure ventilation due to the positive deflection in the airway pressure in the pressure time graphic. Now, in the arterial waveform, you're seeing variation based off what the patient's doing on their positive pressure ventilation respiratory cycle. So long story short, arterial blood pressure drops during positive pressure ventilation. However, looking at the arterial blood pressure tracing sometimes to confirm this can be tricky or deceiving. The arterial blood pressure may actually rise during the initial inspiration. This occurs for two reasons. First, we see about a 2 to 3 beat heartbeat delay in the arterial tracing in relation to the patient's inspiratory and expiratory cycle. Second, sometimes we can see an initial rise in the arterial blood pressure at the beginning of the inspiration. This is because we see 2 to 3 beats ago when the LV preload and LV stroke volume hemodynamics were maximized due to the exhalation. If this seems too confusing, just remember that the LV stroke volume, cardiac output, and arterial blood pressure drop during inspiration and positive pressure ventilation. And again, why does this happen? Let's reiterate. Let's follow the plumbing through the heart. We're on positive pressure ventilation. This decreases venous return. This results in a reduced RV stroke volume. In addition, due to the positive pressure ventilation, there's an increase in RV afterload. So the net effect of this is a reduced left heart preload, resulting in reduced left ventricular preload, stroke volume, and cardiac output. So we'll demonstrate how we can use this physiology as a monitoring technique later on in this presentation. Another concept to reinforce is ventricular interdependence. So we all know that the RV and LV share a tense pericardium, and we also know that the RV and LV share a septum. So to abbreviate this important concept, the RV and LV must share the interventricular septum, and I always use the saying, they need to play well with each other in the sandbox. Because if not, we know changes in this coupling, changing in this sharing relationship can compromise cardiac performance. While this applies at all times, I think the best way for me to teach this quickly is to use a specific situation of RV failure with positive pressure ventilation. So in RV failure, there's two things trying to kill the patient. One we'll discuss in our RV failure lecture, but the second is the RV being under pressure and or volume overload, and this dilates the RV, and it displaces the interventricular septum, and then it actually impinges the LV, the left ventricle. So this can prevent the left ventricle from filling and ejecting appropriately. This dumps the cardiac output and the forward flow. So now let's add extramural pressure in the situation, and this is going to worsen everything. So what's that extramural pressure? It's the positive pressure ventilation in the inner thoracic space. So again, exaggeration of the concept, but I believe that this really gets the fact across that ventricular interdependence is very important when we're talking about hemodynamics and cardiac stability. Now let's move on to talking about hemodynamic pressures, and we'll start with the right atrial pressure. So the right atrial pressure, also known as the CVP or central venous pressure. So as long as the tricuspid valve is healthy, the right atrial pressure reflects the right ventricular end diastolic pressure, so i.e. right heart pressures. What's normal? Anywhere between 2 to 6, but again, I urge you to remember the averages. So the average or the mean right atrial pressure is 4 millimeters of mercury. But again, I want to remind you that pressure does not reflect volume. Now, there's really two common ways to measure the right atrial pressure. One is with an indwelling catheter. So we could put in a central venous line in which the tip terminates in the distal SVC atrial junction. Or we can measure a right atrial pressure with a PA catheter, which is what you see in the graphic here. Another way to measure right atrial pressure is estimate it via echo. However, there's many inherent flaws, and I would view this as a loose estimation. As you can see from the grid, there's really no echo magic to be done here. You're looking at the IVC diameter and the degree of IVC variation. Then this categorizes the patient into an estimated right atrial pressure. But as you can see, the groups are pretty wide. In normal, you're averaging around 3 millimeters for a CVP, intermediate around 8, and high around 15. We're going to utilize this graphic for the next 10 minutes of discussion to sequentially follow the cardiac pressures through a PA catheter, a pulmonary artery catheter. So again, we're talking about right atrial pressure. We're measuring the pressure within the right atrium. And then let's take a closer look at this waveform. So it's important that we're discussing waveform analysis. All too often, I see clinicians only looking at the numbers on the monitor and not evaluating the waveform. And this is definitely not ideal. Let's take a closer look at the right atrial / CVP waveform. So we have an ACV waveform with an XY descent. Let's break that down into some more digestible pieces. The A wave correlates with the right atrial contraction. The C wave correlates with the closure of the tricuspid valve. The X descent correlates with atrial relaxation. The V wave is the passive atrial filling. And then lastly, we have the Y descent. So this is where the tricuspid valve opens, the atria empty, and the RV passively fills. When we compare electrical, i.e. EKG, versus mechanical, i.e. pressure monitoring, we see a delay of about 80 to 100 milliseconds, which you can see in the graphic here. Next, let's talk about actually measuring the CVP. So just looking at the monitor's numbers may not be accurate. You need to visually measure the CVP, the right atrial pressure at end expiration. And we've already learned that that pressure, that end expiration, is going to be in different locations depending if you're spontaneously breathing off the ventilator versus if you're on the ventilator. So it's actually important to go in, freeze the waveform, and use the cursor to measure the exact right atrial pressure / CVP. Once we have that cursor activated, we want to measure by bisecting the A waveform so that the waveform is equal above and below the cursor. Let's take a look at some pathogenic CVP waveforms and how they can help us clinically. If you need a reference at any time, there's a normal CVP waveform tracing in the upper right corner. Looking at window 1, we're missing our A wave. This tells us that the atria is not contracting and can indicate atrial fibrillation. Let's take a look at window 2. We're seeing what we call Canon A waves. It's where the A and the C wave hit at the same time. We can see this during heart block. We can also see it during some forms of cardiac pacing. To me, the atrial contraction is mistimed or desynchronous. Now let's take a look at window 3. We're seeing what we call fusion CV waves. You can see the large exaggerated V wave. This would be indicated regurgitated flow coming back towards the atrium. Now let's take a look at window 4. We see a very prominent A wave. And this really can occur anytime there's a backward force in which the right atrium has to overcome a greater pressure. So we can see this in tricuspid stenosis, pulmonary stenosis, really any type of RV failure. Now let's take a look at window 5. And here we're seeing signs of tamponade. And what's occurring, we're seeing a failure of the Y descent. And this occurs due to the failure of the right atrium to empty appropriately, as well as the RV to passively fill. This is secondary to pressure or compression between the heart or pericardium. Moving to right ventricular pressures. Unfortunately, we can't measure right ventricular pressures with an indwelling catheter. The last thing we want is the tip of a catheter that's flinging around in the right ventricle. So the measure of the right ventricular pressures is actually done with a pass-through of a catheter. The best we get in the ICU is a one-time transducing of this pressure when we float a PA catheter from the right atrium, the right ventricle, into the pulmonary artery. So given this circumstance, as long as the tricuspid valve is healthy, we defer to the right atrial pressure, the CVP, as a surrogate of the right ventricular end diastolic pressure. Let's take a closer look at a right ventricular pressure. The peak here, we see the right ventricular systolic pressure, and then the trough or runoff, we see the right ventricular end diastolic pressure. Our VSPs range from 15 to 30, while right ventricular end diastolic pressures range from 2 to 8. I try to average or mean those in my mind, so an average right ventricular pressure is about 25/4. Now, we can also measure right ventricular pressures with echo. We use continuous wave Doppler, and we also take advantage of the Bernoulli formula. I obtain my max jet velocity of my tricuspid regurg, and then I also get an estimate of my right atrial pressure using IVC size and variation. As long as there's no pulmonary stenosis, we can deduce that the estimated right ventricular systolic pressure equals the pulmonary artery systolic pressure. The echo approach should only be used as a screening tool. There's inherent flaws of echo-derived right atrial pressures, as we've already discussed. In addition, any area in measurement of me obtaining my max jet velocity off my tricuspid regurg is actually squared. It amplifies, it multiplies my error. So in my opinion, there's a moderate risk of error. Next, let's move on to our pulmonary artery pressures. And again, let's take a closer look at pulmonary artery pressures. So the big thing you see in this waveform that's different from looking at a right ventricular pressure are these diacrotic notches here. And the diacrotic notches are indicative of the pulmonary valve opening and closing. So the average pulmonary artery systolic pressure is 15 to 30. The average pulmonary artery diastolic pressure is 8 to 15, but most importantly, the mean PA pulmonary pressure is between 9 to 18. So averaging a PA pressure is 25/10. I would like you to take note that a mean PA pressure greater than 20 is indicative of pulmonary hypertension. Now let's take a closer look at the differences between a right ventricular pressure and a pulmonary artery pressure. If you look quick, you may be tricked. So taking a very close look here, over in the pulmonary artery pressure, you see a clear, distinct diacrotic notch indicating that pulmonary valve closing. You do not see that in the right ventricular pressure waveform. In addition, the pulmonary artery diastolic pressure is higher than the right ventricular end diastolic pressure due to the resistance. Let me show you why. What exactly is the pulmonary artery pressure? So it's the pressure the RV is ejecting blood into the pulmonary circulation and the resistance from flow through the pulmonary circulation. We can understand this with the formula of pressure equals flow divided by resistance. Next, let's explore the pulmonary artery occlusion pressure. Now, pulmonary artery occlusion pressure, pulmonary capillary wedge pressure, and pulmonary artery wedge pressures are all the same things. Don't get caught up in people's narratives explaining their existential explanations of why they're different. They are the same things. Please take special note that in this graphic, at the edge of the catheter, a balloon is occluded. A balloon is blown up. And we're measuring the pressure at the very distal portion, the very distal port of this catheter. So essentially, the way to think about it in your mind is that that catheter is looking through the pulmonary arteries, through the lungs, through the pulmonary veins, and looking at the pressure in the left atrium, the left atrial pressure. The PA occlusion pressure reflects the left atrial pressure under quote-unquote perfect world conditions, and we'll talk about that in just a moment. Let's take a closer look at the PA occlusion pressures. We have ACVY waveform. This graphic depicts the waveform difference between a PA pressure and a PA occlusion pressure. It's definitely not subtle. This graphic shows the waveform progression as you float a PA catheter. From left to right, you see the catheter in the right atrium demonstrating right atrial pressure waveform, moving through the right ventricle with RV pressure waveform, into the PA with PA pressures, and into a pulmonary occlusion pressure showing PA occlusion pressure waveform. The association of the waveform component to mechanical actions can be seen in this blue box here. The A wave is the left atrial contraction, the C wave is the mitral valve closing, the V wave is the LA filling and the LV contracting, the Y descent is the opening of the mitral valve, the emptying of the atrium, and the passive filling of the LV. Normal pulmonary occlusion pressures range from 6 to 12, some will say 4 to 12. A PA occlusion pressure greater than 15 suggests left heart failure. Now let's take a look at some pathogenic examples of a PA occlusion pressure. We can once again see an absent A wave. This would indicate not sinus rhythm, most likely atrial fibrillation. We could see a large prominent A wave, and really we could see this in any situation of LV failure, mitral stenosis, or ischemic LV. And we could also see a large prominent V wave, which you see in the graphic over to the left here, and this could indicate regurgitated flow coming back to the left atrium. Measuring PA occlusion pressures can be a bit tricky, and they really should be taught at the bedside by an experienced operator. Again, remembering that we're going to measure our PA occlusion pressure just like our right atrial pressure at end expiration. We need to understand the difference in the pressure waveform in a patient that is spontaneous breathing versus a patient that is on the ventilator. The graphic to the right, you can see that there is PA pressure waveform. The assistant inflates the pulmonary artery balloon. In a balloon up situation, this converts the waveform to PA occlusion pressure. At this time, the waveform is freezed, the cursor is dropped in end expiration, and the A wave is bisected to obtain the number/value. So let's do a quick recap here. Let's just reinforce what this PA catheter is doing for us in this pulmonary occlusion pressure. So here our infamous yellow PA catheter lights up. We have our balloon inflated. So this essentially causes a blockage of any flow proximally to that balloon. Now, is that factual? No, but in theory, this is how we should think about it. We then take our measure from the very distal portion of that catheter. It's made a static column in which we can look through the pulmonary artery, into the lungs, the pulmonary vein, and look directly in the left atrium to determine the left atrial pressure. Again, let's start from the beginning. The right atrial pressure reflects the RV end diastolic pressure as long as the tricuspid valve is healthy. The PA occlusion pressure reflects the left atrial pressure, the left heart pressures. And if you were to take that one step further with a functioning mitral valve, the PA occlusion pressure could reflect the left atrial pressure, and the left atrial pressure could reflect the left end diastolic pressure. The way I think about it in my head, though, that's a perfect world. That means I have to have a good-looking heart, good working lungs, and good working heart valves. Unfortunately, that does not happen much in our patient population. These assumptions can be inaccurate if there's poor LV compliance, there's positive pressure ventilation, the person has something wrong with just about any valve, their aortic valve, their mitral valve, if they have pulmonary disease, ARDS, and obviously if they have lethal pathology like tamponade. I again do want to reiterate the assumption that in a perfect working heart, valves, and lungs, PA occlusion pressure equals left atrial pressure, which equals left ventricular end diastolic pressure. Now let's move over to the left atrial pressure. So again, the PA occlusion pressure reflects the left atrial pressure. We normally measure this indirectly. Normal is about 4 to 12. There are other ways to measure or estimate left atrial pressure. We can estimate left atrial pressure by echo. We can transiently transduce left atrial pressure when a cardiologist does a left heart catheterization. Interventional cardiologists can also do a transeptal puncture where they go through the right atrium, puncture the septum, and they're in the left atrium and can transduce this. Obviously, this is not done routinely. And then lastly, we can see left atrial pressure lines in cardiothoracic surgical patients. And this catheter is placed in either a left atrial surgical anastomosis or more commonly via a puncture of the superior pulmonary vein, which is then fed back into the left atrium. A cardiothoracic surgeon does this at their discretion in a patient that may have severe LV dysfunction, severe mitral valve disease, or severe pulmonary hypertension. If you do come across a patient with a left atrial pressure line, always remember to pull that left atrial pressure line before discontinuing any chest tubes. And now we move to a left ventricular end diastolic pressure, and really the gold standard is through a left heart catheterization. In this graphic you see in the right upper corner, this is a pigtail catheter that's come through the aortic valve and is now in the LV, and they're actually doing an LV gram. That's where you see the contrast. But within that pigtail, they're able to transduce the pressure of the left ventricle end diastolic pressure directly. In addition, you can estimate left ventricular end diastolic pressure with echocardiogram, utilizing the E to E prime. Normal values of a left ventricular end diastolic pressure are around 8, Anything greater than 15 equates to LV failure. In fact, in evidence of hyperperfusion, a cardiac index of 1.8 and a left ventricular end diastolic pressure greater than 15, we can diagnose cardiogenic shock. Lastly, let's take a look at systemic arterial pressure. I take the extra time to point out arterial waveform analysis because this is another example that I just see folks looking at the monitor's numbers. There's so much more information to be gained from here. Let's take a look at the arterial waveform that you see here in the left portion of the slide. So you see a rapid upstroke, you see a peak systolic pressure followed by a systolic decline, you see a diacritic notch, which indicates the aortic valve closing, and then you see a runoff into the end diastolic pressure. Time differences in electrical versus pressure waveform varies between 120 to 200 milliseconds, which you can see here in the rightward graphic to your slide. Now, mean arterial pressure can be calculated by 1/3 of systolic blood pressure plus 2/3 of diastolic blood pressure. But also, as we take a look at the area under the curve of this arterial pressure waveform, this is our arterial pressure, and the mean of that is, yes, our mean arterial pressure. What I'd like you to see in the right portion of this slide, depending on the relation to the distance from the aorta, arterial waveforms will display differently. So what if I were to tell you these 3 variations of waveforms are the same patient? A pressure line in the aorta, in the femoral, and the dorsalis pedialis. So why does the dorsalis pedialis arterial waveform appear hyperkinetic with a higher systolic peak as opposed to the aortic waveform? And that's a simple answer. The dorsalis pedialis is further away from the aorta and there's more resistance. There's a quicker upstroke to the dorsalis pedialis waveform due to the resistance. Interestingly though, the mean arterial pressure of all 3 of these waveforms are the same. This is why we must really look at the mean arterial blood pressure and not just systolic and diastolic pressure, especially in regards to end organ perfusion. Now let's take a look at some abnormal arterial waveform pressure tracings. So the first here you'll see in the red highlight would be a hyperkinetic pulse, a very quick upstroked pulse. Following the red box here, you see pulsus ultrans. You can see this in advanced heart failure, pointing out every other beat has a variation. Next would be pulsus bisferians, and you see this with aortic valve insufficiency or regurgitation. Followed by pulsus parvus. This is a weak, late pulse. Sometimes you see this in severe aortic stenosis. And then lastly, probably the most commonly appreciated abnormality in arterial waveform analysis would be pulsus paradoxus. And you see arterial pressure variations depending on the patient's inspiration and expiration. Now let's move forward and discuss resistance. In this case, systemic vascular resistance, SVR. What's a good definition of SVR? It's resistance the blood has to overcome to pass through the systemic vasculature. So in a steady state within the body, the main contributor is really vessel diameter, i.e. vasodilatation, i.e. vasoconstriction. Any measure of resistance needs to be known it is a calculation, and that calculation is derived off this formula. Resistance equals change in pressure divided by flow. So in this case, SVR equals MAP minus CVP times 80 divided by cardiac output. Normal is 800 to 1200 dynes. We need to get in the habit of indexing all of our values based on body surface area. So to do that, we would do the same formula, but instead of using cardiac output, we would use the cardiac index. And normal there is 1970 to 2390 dynes. Now, the majority of the folks watching this session will normally see their SVR displayed in dynes, not Wood's unit. So we're going to save that for pulmonary vascular resistance here in just a moment. With that said, the next discussion point is pulmonary vascular resistance, PVR. So if we're looking for a simple definition, it's the resistance that blood has to overcome to pass through the pulmonary vasculature. And once again, the main component of that is vessel diameter. Again, this is a calculation. Again, we use resistance equals change in pressure divided by flow. And with that, we have PVR is equal to the mean PA pressure minus the PA occlusion pressure times 80 divided by cardiac output. Now, normal is less than 250 dynes, and this is according to the majority of the hemodynamic references you can get your hands on. But if you were dealing with pulmonary hypertension every day, you'd probably say it's more like 30 to 180 dynes. Again, we want to get used to indexing all of our values. So to do a PVRI, we're just using the cardiac index instead of the cardiac output, and a norm there is between 255 to 285. If you're a pulmonologist or a cardiologist that deals with pulmonary hypertension a lot, you'll be more familiar with Wood's units. So how do I convert from dynes to Wood units? And it's actually pretty easy. It's a factor of 80. So you take your dynes, second centimeters to the negative fifth power, and you divide it by 80 to get your Wood unit. So an example of that would be 200 dynes divided by 80, and this would equal 2.5 Wood units. This again is important in the field of pulmonary hypertension. A cutoff value of 3 Wood units is used when classifying pulmonary hypertension. Now let's move on to flow. We covered stroke volume and cardiac output in our shock introduction session, but to briefly recap, we understand that cardiac output equals heart rate times stroke volume. A normal cardiac output ranges from 4 to 8 liters per minute, but we want to remember to index that value based on your body surface area, so then we have a cardiac index. A normal cardiac index is 2.5 to 4 liters minute per meter squared. We covered the importance of heart rate in the cardiac output equation, as well as stroke volume, and we understood that a normal stroke volume ranged from 60 to 100 mLs per beat, and that we should index that stroke volume with a stroke volume index, normal being in the low 30s to mid 40s. Instead of being redundant and further covering those topics, what I really wanted to do was go over various cardiac output and stroke volume modalities in terms of hemodynamic monitoring. Let's start with indirect Fick equation. The formula for the Fick equation is VO2 divided by SiO2 minus SVO2 times hemoglobin times 1.34 times 10. Don't worry, this is what we have our calculators for. Roughly, this is a mathematical formula that states that the rate of oxygen consumption must equal the amount of oxygen delivered versus what is returned and used by the body itself. A few things to point out here. 1. The Fick equation is over 120 years old. The Fick equation was not created for the critically ill patient. Technically, VO2, oxygen consumption, needs to be measured. It's obtained with a metabolic cart. I haven't seen one of those in about 2 decades. So we essentially guess what the VO2 is. A lot of calculators are fixed for 200 mLs per minute. Some other ones have a loose equation or a nomogram it follows. But it's presumed, it's estimated, it's not accurate. And lastly, I see that we really reach for the Fick equation when we don't like the data that other modalities are giving us. There's scattered literature out there, but my favorite would be from the VA CART program trial. And essentially, in comparison to thermal dilution cardiac output, Fick equation only showed a modest agreement. And more importantly, the thermal dilution cardiac output values were more strongly associated with mortality. So there continues to be question concerning the accuracy of Fick equation in the critically ill. The next modality to discuss is thermal dilution. The original thermal dilution technique involved true injectate into the PA catheter. Injectate was injected in the proximal infusion port. The fluid came out in the proximal port in the right atrium. And due to the injectate being a differing, lowering temperature than the body temperature, a thermistor, essentially a thermometer at the end of that catheter, registered the difference in temperature. A complicated algorithm and computer-aided model would then give you a cardiac output by showing you and depicting these cardiac output curves. Back in the day, we would actually use iced injectate. Nowadays, facilities that still use this manual method will just use a room temperature injectate. A second type, a more modern type of thermal dilution, is a continuous cardiac output PA catheter. Essentially, there's a copper coil in the proximity of the right atrium which heats up. This change in temperature is then read by the thermistor, the thermometer, at the distal end of this catheter. And again, there's a complicated algorithm and computed model which gives us a cardiac output. Thermal dilution is probably the most popular or best known cardiac output modality. Obviously, it is invasive. And there are downfalls of cardiac output thermal dilution as well. If there's severe tricuspid regurgitation, the PA catheter will underestimate the cardiac output. If there's intercardiac shunts like a VSD, the PA catheter will overestimate the cardiac output. PA catheters in VA ECMO obviously alter the majority of the hemodynamics. However, the continuous SVO2 and some filling pressures may still be able to be utilized. In addition, if you're doing the manual injectate method, using a bolus technique, a bad injection technique can alter your interpretations and values of cardiac output. The next modality is echo-derived. We can get echo measurements, echo-derived modality values from a transthoracic echocardiogram, a transesophageal echocardiogram, and also an esophageal Doppler probe. In this example, we're using transthoracic echo. We're measuring the left ventricular outflow tract diameter, as well as obtaining the velocity timing integral of the aortic valve. Another more advanced technique would be utilizing a transesophageal Doppler probe in which aortic flow Doppler technology is utilized. A more familiar modality is pulse contour analysis, which is a minimally invasive cardiac output and stroke volume modality. You need an arterial line that's optimally dampened, and if you want to calculate SVR, having a CVP or right atrial pressure is needed. There's two types of pulse contour analysis equipment. There's calibrated versus non-calibrated. The non-calibrated methods use a database and nomograms and proprietary algorithms to understand the cardiac output and the stroke volume. Important to point out with this technology, the majority of them are only validated in the OR operative setting. So there's continued concerns to understand if the accuracy is still reflected in patients that have a low SVR syndrome, such as distributive shock, i.e. septic shock. So with that said, accuracy is always in question. And then remembering, because we're analyzing pulse contour, anything that affects the arterial waveform will affect your output, will affect your accuracy. So this could be a balloon pump, it could be VA ECMO, an axial flow device, or bad arrhythmias. The other thing that needs to be remembered is that this modality assumes a normally functioning right heart. If the patient's in bad right heart failure, this can affect the accuracy of this modality. I think the best practice of using this technology is to use pulse contour analysis, but also to use your bedside echo to understand the condition and performance of the heart prior to initiating pulse contour analysis. Lastly, we have bioimpedance and bioreactance. Now, these are truly non-invasive technologies. Due to the accuracy and limitations to bioimpedance, however, I'm going to focus my discussion on bioreactance. When using bioreactance, there's 4 lead packs placed to the skin of the thorax. And this is a pretty wild technology. It assumes the changes in the interthoracic blood volume during the cardiac cycle induces changes in the electrical conductivity of the thorax. So conductivity changes are detected by skin electrodes assessing the difference between the input and the output voltage of applying a low amplitude, high frequency current to the thorax as seen in the graphic that you can see here. So bioreactance assesses for pulsatile flow-induced frequency modulations and what we refer to as phase shifts in the voltage across the thorax. So essentially, the bigger the phase shift, the bigger the stroke volume. And this the computer bases on the ventricular ejection time and the slope of the change in the aortic volume. Now that we've moved through some cardiac output and stroke volume modalities, let's move on to some important formulas. The first being cardiac power output. Cardiac power output, or CPO, equals MAP times cardiac output divided by 451 watts. A CPO value less than 0.6 is associated with increased in-hospital mortality in the setting of cardiogenic shock. Cardiac power was found to be the strongest hemodynamic correlate of mortality in cardiogenic shock according to the shock trial registry. This is essentially translated to a preventative reactive value to implement escalating therapies in cardiogenic shock to hopefully improve outcomes. Next, we have our pulmonary artery pressure index. We call this our PAPi. PAPi is equal to pulmonary artery systolic pressure minus pulmonary artery diastolic pressure divided by right atrial pressure. Essentially, this is a predictor of mortality in RV failure. It's best studied for identifying the need for RV mechanical circulatory support in acute inferior MIs, as well as end-stage heart failure undergoing LVAD implantation. We know that the PAPi outperforms right ventricular stroke work index and the right atrial pressure PA occlusion ratio. A PAPi index is independently associated with survival in pulmonary hypertension, progressive AKI and heart failure preserved ejection fraction, postcardial pulmonary bypass RV dysfunction, and lastly AKI after heart transplantation. Speaking of the right atrial pressure, PA occlusion pressure ratio, this ratio is based on a simple concept. At no time should the right heart pressures try rivaling the left heart pressures. In normal conditions, the right atrial pressure is much lower than left atrial pressure. So this is a ratio that helps scream there's a disproportionate increase in right versus left heart pressures. And this can help discern isolated RV failure versus BiV failure, and it's also useful when assessing that right heart during LV mechanical support. Pinning down a normal range is a bit tough. In the cited heart failure paper here, the median ratio was 0.58 with a range between 0.43 and 0.75. But again, this patient population wasn't full of healthy hearts. A more recent guideline on mechanical circulatory support during heart and lung transplantation recommends a cutoff threshold of 0.63 to demonstrate right heart dysfunction. An increasing ratio is associated with a drop in GFR, increased mortality, higher PVR, reduced RV function, and increased adverse outcome. Next, we're going to take our heart-lung interaction knowledge and apply that to heart-lung variation hemodynamic technology. A huge challenge in the ICU is figuring out who to give fluid to. Only about 50% of our patients will be true fluid responders. The other 50% we could hurt by giving fluid to. A definition of a fluid responder is defined as an increase in stroke volume or cardiac output by at least 10% after a volume bolus. If you think about it, the only goal of volume resuscitation during shock is to improve stroke volume and cardiac output. Otherwise, there's negative consequences of giving patients that don't need fluid. We're going to discuss this in much more detail in the next critical care shock session on volume resuscitation and fluid responsiveness. In heart-lung variation hemodynamics, we're going to take advantage of the known variations in arterial blood pressure and stroke volume during the respiratory cycle to help us understand if the patient would benefit from fluid resuscitation. And while we'll discuss this much more extensively in future sessions, heart-lung variation hemodynamics is an excellent tool. Using a threshold of 11 to 13% in variation, we can use this technology to indeed understand if a person needs fluid resuscitation. Dr. Merrick et al. Actually did a meta-analysis consisting of 29 studies comparing and assessing the accuracy of heart-lung variation hemodynamics. His meta-analysis compared varying forms of cardiac output and stroke volume analysis to heart-lung variations of systolic pressure variation, pulse pressure variation, and stroke volume variation. The heart-lung variation technology correlated very well, they performed very well, and had favored specificity and sensitivity. I will point out this study for inclusion criteria, the patient had to be on controlled mechanical ventilation with no spontaneous breathing, and the tidal volume had to be greater than 8 mLs per kilo of predicted body weight. However, there's multiple limitations of heart-lung technology. So the patient needs to be mechanically, passively ventilated. That is no spontaneous breathing at all. They need to be in a sinus rhythm. Their tidal volume has to be at least 8 mLs per kilo of predicted body weight. They need to have a closed chest. They can't have any increased abdominal pressures. And again, this heart-lung technology assumes a normal functioning right heart. So let's go ahead and wrap this session up. We're going to continue to build knowledge based on our principles of cardiac output, venous return, and oxygen delivery. We're going to continue to memorize anatomy, flow, and normal average pressures. We're continuing to integrate the concepts of pressure, resistance, and flow. I want to keep highlighting the applicable monitoring technologies that are out there. And last but not least, don't forget about the patient. With all these bells and whistles, it's easy to forget about the patient. Hemodynamics are only part of the puzzle. Looking at our shock reference sheet, hopefully this session has helped you understand the hemodynamics to better classify various types of shock. This concludes our Critical Care Shock Series session. I appreciate your attendance. If you have any questions or anything to add, please feel free to email me at learn@ross-educate.com. Thank you.